So welcome again tonight. We're going to be discussing the PEARR Tool. My name is Amy Sharpe. I'm one of the co-chairs for the Health Subcommittee of the San Diego County Human Trafficking and CSEC Advisory Council. If you have a question or a comment during the presentation, please feel free to interrupt me. I might not see you raise your hand or put something in the chat window, so don't be shy about that. So what we want to cover tonight is how the PEARR Tool empowers patient dignity and autonomy. It addresses a continuum of abuse. And it is a trauma-informed instrument. So although this is, we're trying to address human trafficking, there are a lot of other abuses that intersect with that or overlap with it. Also, and Kat will get into this more, but because human trafficking is not something that's regulated, that we need to address, I guess. It covers those things that are, and it helps us to include human trafficking in that process. So that's one way to get the stakeholders to address this if they're unwilling to make changes. Also, it helps to support patients with community agencies and resources. So this PEARR Tool was developed with a partnership with Common Spirit, which was formerly known as Dignity Health. And some of you might be more familiar with that name, but they've been absorbed by Common Spirit. And Pacific Survivor Center, which they serve a whole spectrum of survivors of different types of violence, and then Heal Trafficking, which is a physician-led multidisciplinary network that's addressing trafficking. It is an evidence-based framework, and it's based on the trauma-informed and patient-centered cues model. This is the part that I really want to drive home, is that it recognizes that creating an emotionally and physically safe context is often more effective than a checklist or screening tool. So we tend to be like in a clinical environment, we want to screen in or screen out. This is a little bit more squishy, so it's an assessment tool. But if we do it correctly, it is more effective than a screening tool that often alienates patients. They submitted this for a grant with the Department of Justice, and the validation process will be completed in September of next year. So we can expect in a few months to be hearing some helpful information about what they learned. So these are the abuses that are addressed by the PEARR Tool: child abuse and neglect, abuse and neglect of vulnerable adults. That includes intellectual and physical disabilities, as well as vulnerable seniors, intimate partner violence, sexual violence, and human trafficking. So trauma-informed care is an organizational structure and framework that involves understanding, recognizing, and responding to the effects of psychological trauma. And that's kind of what's confusing about it, because people that are in medicine tend to think of trauma as something physical. And the name of it can be confusing for that reason. But it also emphasizes that this care, somebody needs to mute themselves, please. That if we create a physical and psychological and safe environment for the patient and the providers, it helps to build a sense of control and empowerment. This also relates to just culture. Tessa, can you give us just a quick synopsis of what just culture entails?
Yeah, so it's something that we enact at our organization at Planned Parenthood, and the idea is really that when we make mistakes, even if they don't end up impacting patients or don't end up impacting any other colleagues or anything like that, that it's important to step forward and address those things, because it ultimately lends to us addressing like the systemic flaw that led to that mistake. And it's not a punitive measure, it's just a look at the processes that we use to see if there's room for improvement.
And that culture really does translate to patient care. When the clinicians feel comfortable learning from each other and from each other's mistakes and supporting each other in process improvement, it really does translate to how the patients feel and are treated as well. And I think especially now in times of COVID, those stresses and unfortunate outcomes can be really stressful. And so that lends itself to the resilience of the staff, which is really important. So the 4 R's of trauma-informed care. First, we need to realize that psychological trauma is not incredibly rare. It happens to a lot of people for lots of reasons. Veterans, people who experience childhood trauma, people who experience sexual assault. So it's important for us to realize that literally anyone can be impacted by the residual effects of psychological trauma. And because of that, we need to recognize the signs and symptoms of that and know how to respond appropriately. And that's why we need to use tools like the PEARR Tool or other policies that integrate trauma-informed care, things like maybe putting the patients back to the door if they have PTSD is going to make them feel very uncomfortable. And so just even the way we design our spaces can make a difference. And then the last part, resisting re-traumatization. With the PEARR Tool specifically, I would say that the biggest part of that is we only want to get enough details to understand what resources and support they need and what medical care they need. If you don't want to open that can of worms, if you're not professionally equipped to help them through that healing process, you want to make sure that that's done by somebody who is equipped to help with that. And I apologize, I clicked on the hyperlink that's in there. There we go. So the 6 guiding principles of trauma-informed care are first, safety. So like that example that I said, putting a patient's back to the door might not be a welcoming environment. Trustworthiness and transparency. If you're going to include another clinician or social worker in that experience, you want to make sure that you have the patient's consent and understanding before you do that, so that you don't undermine the trust that you've established. Peer support, it really does help for them to be connected to individuals who had a very similar experience to what they've had. And collaboration and mutuality, if they're ready to ask for help, you want them to be part of that planning process so that they feel invested in the outcome and they feel like it's what they want. And that goes hand in hand with empowerment, voice, and choice. Things like shared decision making make a big difference. And then the cultural, historical, and gender issues. Eric could go on for days about how male survivors are not, usually acknowledged or receive the kind of support that they deserve. So we need to keep all of these different dynamics in mind as we go through this. And this is why we're going to have a dedicated continuing ed event on trauma-informed care coming up in the near future, so that you get the whole package of this. But that's just a quick summary. So the PEARR Tool, we first provide privacy, educate, ask them about their experience, respect their response, and then respond with appropriate services. So ideally, a room with a closed door where they can have a private conversation about very sensitive things. It's important to plan ahead non-threatening strategies that help separate the patient from the companions that they may have come in with, and never use a companion as an interpreter, because they might be involved in the exploitation or complicit with it. But if you can't separate them, which happens, it's important to prioritize the patient's safety. Don't push the issue, and make sure they get the medical care that they're there for. Also, it's really essential to explain the limits of confidentiality. And Dr. Titchen, I know you've had some experience with this. Do you have any comments that you'd like to share?
Sure. I would just strongly recommend sharing those limitations up front before you solicit any information from especially youth who you might need to be a mandatory reporter for. And I also am very careful about the language I use. So I never talk to a patient about the need to report anything, because especially with patients who are trafficked or who have encountered law enforcement, reporting is equated with something negative and punitive. I think, as Tessa already addressed. So really what I talk about is if I hear anything that makes me concerned for the patient's life or well-being, going to self-harm or because somebody else is going to harm them, then I will need to get help in that situation, because that's more than I can handle alone. And usually I would reach out to a parent, but it's very situation dependent, because sometimes we see that parents are traffickers. So again, I would just disclose that before having any private conversation or asking for any information from the patient, just to make sure that they're clear that if they do choose to share, the information may be something that warrants getting a higher level of care and a higher level of attention.
Thank you. And with that, like the times that need to be reported are like when it's a minor, and that's even if it's concerns you can't prove something. If you have concerns that there's neglect or violence or exploitation happening, that's a mandated reporting situation, and the same with vulnerable adults. So universal education shows concern for safe relationships or human rights and is normalized as a routine health question. So the important distinction here, and this was sent out in the email I did a couple of weeks ago, where there was a webinar in February that interviewed survivors of labor trafficking, and they said that the biggest obstacle for them asking for help was that they weren't clear what their rights were, and so they didn't know what was acceptable. So where domestic sex trafficking, the ideal is to educate about safe relationships with migrants, regardless of whether it's labor or sex trafficking. What they really need to know about is what their rights are, so that they know that it's safe and okay and wanted for them to ask for help. And also normalizing this conversation addresses biases of both the patient and clinician about their experiences. A lot of survivors of trafficking didn't recognize in the moment that that was their experience. And some of the jargon that we would use wouldn't help them identify that. And so this appropriate, culturally sensitive education makes a difference. With that in mind, it's best to have safety cards on hand, and that hyperlink there has some resources for you to have those cards. And if they don't want to take the card, don't try to push it, because that could warrant a safety risk for them depending on their situation. So the next one is ask, but before we do that slide, I want to share this video with you. And hold on, let me just make sure that my audio is on.
Our first project, the one that has inspired my first book, Ripples from the Zambezi, was a project where we Italians decided to teach Zambian people how to grow food. So we arrived there with Italian seeds in southern Zambia, in this absolutely magnificent valley going down to the Zambezi River, and we taught the local people how to grow Italian tomatoes and zucchini. And of course, the local people had absolutely no interest in doing that, so we paid them to come and work, and sometimes they would show up. And we were amazed that the local people in such fertile valley would not have any agriculture. But instead of asking them how come they were not growing anything, we simply said, thank God we're here. Just in the nick of time to save the Zambian people from starvation. And of course, everything in Africa grew beautifully, and we had these magnificent tomatoes. In Italy, a tomato would grow to this size, in Zambia to this size. And we could not believe. And we were telling the Zambians, look how easy agriculture is. When the tomatoes were nice and ripe and red, overnight, some 200 hippos came out from the river and they ate everything. And we said to the Zambians, my God, the hippos. And the Zambia said, yes, that's why we have no agriculture here. Why didn't you tell us? You never asked.
And I love that story, first because it's hilarious. Second, because we've all fed hippos, right? With great intentions. We've done things that were not meaningful or helpful. And that's why it's really helpful to have instruments like the PEARR tool that help us to come back to, okay, what are the appropriate steps for me to assist this patient? And I apologize, I skipped a slide. So we ask, it helps to ask open-ended questions. And again, that fourth R, resist re-traumatization, by just limiting those questions to what we need to determine the patient's safety and the resources that they need. Some of the leading questions that are included in the PEARR tool, I noticed, I'm concerned. You don't need to share all the details to get support. So it helps to facilitate those questions, but it's really what it is it's a way to facilitate a social worker or clinician to let them know we care about this, we want to help if we can, and gives them a way to open up that conversation so that they can listen to what the patient needs. And then respect. And throughout the PEARR document, they have these double asterisks for points where that conversation might end because the patient isn't comfortable with moving forward or something else happens. So, and that's okay. That doesn't mean we failed. It's just part of the process. And that's why they're there that way. And sometimes it helps to ask in a sideways way, not directly, because there is a stigma associated with being a victim of crime. That, if you know someone that needs help, we have resources and you can take these with you. And that can help reduce that stigma. But it's really essential to make sure that the patient feels comfortable and can come back either to your facility or another and receive the medical care that they might need. And then we need to respond. Don't make promises that can't be kept. That's especially true with support services. Sometimes services are not immediately available. And we have the Safe Shelter Collaborative here locally that's going to help alleviate some of that, but it's an ongoing issue, not just locally, but nationally. So just make sure that you know that there's a place for them to go before you promise that. And I know I've said this before, don't include others without permission. And making that warm referral, asking for help can be really difficult. So if you offer to speak to the agency with the patient, that can make it much easier. Make that warm referral, and then they also know what you're telling them, which makes them comfortable as well. So all of these things help to facilitate this process. So having put all of that out there, I wanted to ask you, what do you think success looks like?
For me, in the outpatient setting, Amy, success looks like a patient returning to my care so that I can establish rapport over time and seeing that patient not only get better or heal, but also over many months or years thrive. And that's our aim in adolescent and young adult medicine, is to raise healthy adults and thriving adults.
Excellent. Who else?
I would say for me, when I help with I call it TA services, we have to let the client empower their choice, no matter what it may be. Even if you may set up shelter somewhere and complete wraparound services, at the end of the day, if they choose to go back into an environment that's not healthy, but is safer than the environment they're walking away from, we still have to empower them and let them make that choice and let them come back to us when they're ready for those services. That's from my experience firsthand.
Okay. Other thoughts?
Amy, I'm working with students, and this is why this is so important. And I look at the small things. When I see a student who's been performing and all of a sudden they stop performing, they're quiet, they're the quality of work that they're doing is not up to par. Reaching out to the student, connecting them with their counselor, or and then there's other support systems sooner versus later, because I want to see all the students in the class succeed, especially with one. This is their last for one cohort's their last class. For another cohort, they have one more class. So it's very important that they succeed after 2 years of nursing school, and just being able to identify that there's something going on and helping them to get the support that's needed. This has been very informative because I look at a person differently.
Okay, thanks. Does anyone else have comments they'd like to share?
This is Amy from UCSD. I guess just coming from the emergency department, we don't get to see, patients coming back, or we don't get to see the long term. Generally, we're just pretty quick treatment and out. And so I think for success for us, or for me anyway, it would be to have all these resources available, or knowledge, and just basically success would look like we are doing all we can in the capacity in the emergency department when we do get these patients. So because we won't see them long term, I think for us, it would be that we've done all that we can at the moments that we do see them. So I thank you for this opportunity.
Thanks, Amy.
This is Michelle. Well said, Amy, and then also Kanani, and everyone who spoke already. It's hard to kind of follow up with that. I think success for us, it's the spectrum of where we see the patient and their trauma. So understanding where to meet them where they are and develop that trust and rapport in the empowerment, but also just creating a safe place that they understand, being trauma informed as a practitioner, but also being able to have a trauma informed response and make sure we're giving everyone their options, and again, meeting them where they are and letting them know that there is trust within the healthcare system. So should, depending on what they want at that time, depending on that, we can honor those, their wishes, and then again, be there if they need follow-up. So looks very different, I think, through the life spectrum for us, but overall, it's about trust, rapport, and creating that safe space.
Yeah. Well, and I think out of the survivor stories that I've heard, whether it's a healthcare provider or someone else, it's that person that made them feel safe was the anchor that they kept coming back to before they were able to exit. So thanks, that was well said. Does anyone else have any comments before I move to the next slide? All right, I gave you a nice long awkward pause, so we're gonna move on. So this is the last slide. There's just not a lot of humor that's appropriate with human trafficking, so I took that hippo story to the next level. So success looks like the risk is identified, the patient is educated, resources are offered, and most importantly, the patient feels heard. And some hungry hippos to make it edutainment, right? So I really appreciate your comments, the things that you were able to share, your unique experiences, especially because all of these settings are different. I'm going to transition to Kat so that she can share her presentation. I apologize.
I'm gonna not share my video of myself only because I'm on my cell phone's VPN and I don't want it to get even slower than it is.
Okay.
I'll just show you the PowerPoint, FYI, for everyone.
Sorry, I'm just looking for how do I turn control over to you?
You go on my side and you click Make Co-host, I think. So you would stop your screen, stop sharing your screen, and then you could go under my name and then Make Co-host. Cool.
There we go.
Cool.
There you go. Now you should be able to do it.
Let's try again. Yay, okay, perfect. So I'm just gonna start from the beginning. And this is kind of a quick thing. So the reason I'm talking about this, I have the privilege of being a doctoral student at Johns Hopkins, and for our nursing evidence-based practice quality improvement projects, they gave us this tool which is available online. So I'm giving them all the credit for this. And it's something called the Stakeholder Analysis. So
Amy, I'm not able to see your screen.
Oh, you're not?
No. And while Kat, that's okay. While Kat sorts that out, I just want to give her a proper introduction. Kat, I'm not going to say your name right, so I'm going to let you do that. But she's a student and a postmaster's and is an NECO at Johns Hopkins University. She is a family nurse practitioner and associate clinical nurse faculty, and she's a recent graduate also from the Human Trafficking Education and Training Academy. So thanks for
having me. For some reason, it's not letting me share my screen with you.
We saw a glimpse.
Weird, and can you see it now? Or no?
Yes.
Now we can.
Now we can.
Yes.
Thank you.
Go.
Okay. Little bit of delay. Can you see it now where it says stakeholder analysis?
Yeah.
Oh, great. Okay, so hopefully this works out. Okay, so being that I'm a student, this is one of the tools they gave us as students at Hopkins, and I personally found this tool works in a lot of different healthcare settings, because in order to implement this tool while you're working, you really have to take a look at your stakeholders. So I kind of wanted to go into that. So, you know, as all of us know, and we're part of this committee, that there are studies that show that human trafficking survivors are likely to have contact with the healthcare system during their exploitation, since unfortunately human trafficking leads to negative health consequences. So there was a study in 2014, I can't recall by who at this point, but about 88% of women and adolescents saw a physician during their trafficking. So I wanted to go into the stakeholder analysis tool in order for you to empower yourself in your organization to implement the PEARR tool if that's something that can be done where you work. So part of this tool is identifying your key stakeholders. And who are these key stakeholders in your organization? It's the person, the groups, or the department that have an interest in this or a concern about this, or someone who can help you implement this PEARR assessment tool, this PEARR tool into your clinical practice. And they also may be the person who helps assist you in securing resources to implement your action plan of having this tool being used. One of the things about getting your stakeholders involved is you really need to get them involved early in the process, because that way they see the importance of it. So there's a form that can be used for the Johns Hopkins Nursing Evidence-Based Practice. And though this is a nursing evidence-based practice form for quality improvement projects, it really can help with the PEARR tool. So how do you start doing this? Well, the first things you need to do is identify the key stakeholders in your organization that can help you implement this PEARR tool. So this could, whoa, it's moving on its own. This can be a, I'm sorry, my thing is moving on its own, even though it's programming not to. So this can be your manager, your direct supervisor. Because implementing tools can cost money for your organization, it's good to get your finance department involved. There could be committees in your organization that are already part of this. So like education committees, for any professional organizations, then looking at some of your organizational leaders, any interdisciplinary colleagues. So some people mentioned physicians. Well, you know, physicians are one of those interdisciplinary colleagues that can be involved in implementing this. Your administrators and other units or departments like the emergency room, urgent care settings in your system, if that's where you work. Then you start looking at the stakeholder roles and responsibilities. So you write down all the key stakeholders that you have in your organization that you think would have an effect on implementing this PEARR tool. And then what you do is you look over the responsibility, approval, consulting, and inform. So what that means is, say you put the person manager, what's their responsibility? What tasks would the manager of your department need to do in order to implement this PEARR tool? Okay. Is there an authority above the manager that needs to be involved? Then you think to yourself, approval. Who would be the person in my organization who needs to sign off on implementing this tool? Then you'd have to go to consult, where you look at your stakeholders and say, okay, who will be the subject matter experts on implementing this tool? Who am I going to reach out to, whether it's within my organization or the outside? Who has decision-making authority and who has no decision-making authority? Then the next part is informing. So all the stakeholders, when you're trying to put this PEARR of my progress and any changes. So once you look at that, the stakeholders' roles and responsibilities.
You cut out a little bit. Could you just repeat that last part, please?
Yes, I think my thing broke because I'm on VPN. I'm just not gonna share this part. I'm gonna talk about. So the last part is, once you look at the consulting, who's gonna provide input? Who are the subject matter experts of the PEARR tool? Like, who are you gonna reach out to? And then as you're progressing and making changes, who do you need to notify of any changes to the PEARR tool or how we're going to implement it? And the next step you do is say this project is, implementing the PEARR tool in my organization or trauma-informed care. Then you can use the Johns Hopkins Nurse Evidence-Based Practice tool or another analysis tool. So you can write down who your stakeholders are, their names, their role, their responsibility. Do you need to consult with them? Are they someone who you need to gather approval? And what step do you need to inform them along the way? And the reason I say this is, this tool is a wonderful thing, but at the same time, you need to be able to implement this tool in your organization. And one of the best ways to do that is to really take a look at the stakeholders of your organization. Because when you identify, say, just to start, these 5 to 7 key stakeholders who this may affect, or their project, the actions, or something that can influence your organization, you're going to be able to know who can make a decision about the project, who can approve this PEARR tool, who can provide you resources, support, and policy changes. And at the same time, you will be able to realize, well, hey, I have this manager, and this manager fills many different roles in completing the implementation of this PEARR tool in my organization. So by doing this and describing the responsibilities of each stakeholder, this is not an overnight process. This can take a very long time, but at least you have a little bit of a stepping stone of where to start. So that's all I just had to say today.
Thanks so much, Kat. Can we, is it okay if I share your slides?
Yeah.
Perfect. Thanks so much. I'm just going to end the
With
recording. Does
thank
anyone have any
you.
questions or comments before we end the recording? Okay, I'm going to go ahead and end it then.